And last guest speaker for today is Attila Farkas. Attila is the Senior Director of Solution Management and Advisory Services at Infoway. Attila will be presenting on patient summaries in the interoperability landscape. Thanks, Attila. Over to you.
Thank you so much, Linda, and hello, everybody. Nice to be here with you today. Let me just share my deck. There, I trust that you can see the screen now.
Yes, we can. Wonderful.
Perfect. Thank you so much. So I believe last year we had the opportunity to do one of the series in the interoperability theme, and I think we touched a little bit on the patient summary, but that particular presentation was solely focused on the patient summary specification. And this time around, we're going to try to show you where does the patient summary fit in the landscape of interoperability and how are we approaching it in the process of developing the specification and then working with the market to ensure adoption of the specification. So we had a couple of objectives here for today. Without going too deep into the subject, we thought we would do a little bit of a quick overview of the patient summary, and especially for those, and I'm not sure if there's anybody from last year that has had a chance to see this presentation, but the specification has been going on for development for the last 18 months, so you may have seen an earlier incarnation of this. We're going to give you an update on where it is today, and then I'm going to start focusing on the interoperability elements associated with it, and say a few words about the approach that we have introduced with the Projectathon and the results of the Projectathon from this year. So I trust that Abby has done an awesome job at already covering the interoperability shared roadmap. I'm not going to go too deep into this, except that I wanted to place the patient summary as one of the high priority areas in the roadmap ahead. Although we have had some limited success already to date, not the least of which is building awareness about the patient summary. We also had a couple of opportunities to work with the vendors to sort of start adopting it. So the train has certainly left station, but we have not yet reached the critical mass with patient summary adoption. And that's why the item number 2 there is something that we are going to be tracking going forward into interoperability roadmap ahead. So diving into it, what is the patient summary and what is PSC and what is IPS? So IPS is a specification born out of Europe. The European community required a couple of years ago some means to create a summary of a patient's record in order to facilitate unplanned medical help when European citizens were traveling across national boundaries. And so after years and years of thinking it through, they eventually came up with a standard that became known as the SEN, the European Standard 17269, and it was very well formulated, and ISO immediately picked it up as an ISO standard 27269. And then it is these two standards that were the beginning of a journey where other international standards development organizations have jumped in and all started picking up the components that are most appropriate for their domain. HR7 International jumped in to define some implementation guidance around CDA documents that could be used as patient summaries, as well as SPIRE documents, which are a little bit more modern, a bit newer technology. And both implementation guides are available. IHE International also created an integration guide, and it suggests a number of the interoperability building blocks that could be used in the process of using patient summary. We developed the Canadian patient summary specification based on the IPS, recognizing that there's probably going to be a number of challenges when you're trying to adopt an international specification that hasn't yet seen wide international adoption. And because of that, we decided that we're going to take a look at IPS adoption and try to do it in collaboration with a couple of Canadian stakeholders. From the get-go, however, we recognize that the only way we are going to be successful with this is if we recognize the dual nature of the patient summary specification as a product, meaning you have to define the content that should go into a patient's summary document, but also the mechanisms by which you can exchange them. Because if these are not standardized, you're going to have a really hard time exchanging it and knowing what systems should expect at each end. So recognizing that patient summary should be a level 2 specification, so content and exchange, we proceeded down the path of creating the alliance of the willing. You can see there on the table, jurisdictions have put their hands up and they wanted to become co-creators of the first version of the patient summary for Canada. And we proceeded down the path of identifying the number of use cases where patient summaries would be very useful. Looking at the scope of the project, we realized quickly that we should probably start with the core use cases. So we chose these 3. And these 3 use cases are fundamentally covering the creation of a patient summary by a primary care physician, for example. The second use case is uploading the patient summary into a central repository from where another physician could query and retrieve it. And then the third one was where the patient would be able to retrieve their own patient summary and consume it, view it and consume it. So having set out to this scope about 18 months ago, after several rounds of review, the first version of the patient summary specification was born. We call it trial implementation version 1.0. I believe this deck is going to be shared with everybody. Therefore, I would highly recommend to go and hover over these links. You're going to see that they actually are links to live web pages where you can find the actual specification. And if you're interested in studying it, you can certainly go down into the depths of this. It's a fairly voluminous, sizable specification. And the way it's structured is it's trying to recognize that dualism that I talked about when I said level 2. There's a core implementation specification that will talk about the transactions and how things come together. Then you have a FHIR content data model. The Pan-Canadian patient summary is designed to be a FHIR document, not a CDA document. And then we have 2 companion guides to the specification, one that talks to the reference architecture, and I'll talk about that a little bit later, and one that talks to the use cases and requirements. And this companion guide was specifically designed to offer implementers guidance on what else they need to take into account if they would like to engage with patient summaries in their environment. So to put everything in one page, we designed this particular picture because it's they say a picture is 1,000 words. What you see in this picture is in one single shot, you can see the universal version of IPS, which is the leftmost vertical, and the PSCA comparatively presented next to it. You can see the only difference is 3 blocks there are not red in the Canadian patient summary. And what that means is we did not want to force the market to absolutely have to provide inclusion of the data that is in the right fields, in the fields on the left, the red fields. We wanted to give the market the opportunity to assemble a patient summary based on the information that they have. And because of that, we lowered the required nature of that into recommended. And then what you see in the center of the picture is the gray rectangles. The gray rectangles represent the area of interest for each jurisdiction that participated in the project to see what kind of capabilities would they want to represent in their patient summaries. We're hoping that over time, we're going to reach a complete coverage. but the first version of the patient summary was reduced to a scope that does not include 2 of the yellow ones, and you can see 4 of the green ones that have not been included. This is obviously expected to be closed, this gap, in the future, and updates to the specification will be included, as well as updates from the International Patient Summary. So going a little bit deeper into the specification, I also have a page here that has the links to the FHIR implementation guide. The FHIR implementation guide is usually a document that's put together. It's very, very useful for implementers that need to code up the data model, because it gives you reference to every single one of the data elements in that picture that you saw in the previous slide. And it also gives you clarification about the type of terminologies that are going to have to tie into the data model. So it's certainly a very useful piece of referential part of the specification. So let me focus a little bit about on the interoperability part. So that was the specification. Pretty much everything that you saw up until now was also presented last year, and it was the journey that led us to the specification. But I thought that this year, because we're talking about the patient summary in the context of interoperability and how does it fit in the landscape, I thought it would be very useful to see why our specification designed this way, and how can we use this methodology to actually apply it to other specifications, not just patient summary, and how approaching interoperability this way will give us the opportunity to create modular capabilities that are going to be reusable in a variety of contexts, not just necessarily patient summary. So in general, IHE International has pioneered, IHE International is an SDO, is a standards development organization, has pioneered the methodology where any complex problem can be broken down into clinical, technical, business workflows, business requirements. And then those requirements can be mapped by technical experts to the standards that are most applicable in the ecosystem. And then taking those detailed models, these workflows, these capabilities can be built into the so-called integration profiles, which are nuggets of capability that are generic enough to be reusable, but specific enough that they can resolve for the use cases that we were talking under number 1. And then finally, the process ends with the market starting to adopt these building blocks. And then those building blocks can be both conformance tested and verified, certified, and they are usually tested in international technical events called connectathons. And in the case of a specification being tested for a national deployment, they're called projectathons. So we employ this methodology in the design of the patient summary specification. And to give you a little bit of a sense as to how this works. Now, you obviously don't need to read this slide. It's very minuscule, but basically what you're seeing on the very left side is, and if you travel to those links that I pointed out, you are going to be able to read this properly in the right format. But what you're seeing there is use case number 1, where a physician is assembling a patient summary, and then the physician is uploading this patient summary to a central repository. So that the entire process, every single one of those steps, gets mapped to a table in the right side. And as you can see on the top, the use case, which is on the left side of the right table, ends up being represented as a required technical service that is going to be solving for the business problem that you're listing. So for example, authenticate the user, identify the patient, you see there in the center. Those are capabilities that a system should be able to do, right? I mean, a doctor would probably log in into their EMRs. They wouldn't just grab a computer and sit down, do something. They would have to identify their patients from client registry, from their systems, and then start collecting the information to populate a patient summary. And eventually that patient summary gets formatted and transferred over to a repository. So taking this right side of the table, you can kind of see how the items that are highlighted in red are service capabilities that others have already identified to solve other problems. So for example, authorizing your users, identifying that the person that's using the service is who they are and that they have the rights for this. This is an operation that's very frequently used in a lot of things, not just patient summaries. So when you told the story and you needed this capability, you can sort of already form that mindset that you could use something of an integration profile that others have identified, and you can piggyback on, and you can use it in your specification. Similarly, for how do you identify a patient? There are integration profiles that have identified this problem, solved for it, and you can use. How do you integrate a terminology set, a value set? That thing is also figured out. And the ones in the red were showing as some of the integration profiles that already have been either solved for nationally or internationally. And then at the very bottom, you can see the CAFAX, we call it. It's the Canadian Fire Exchange specification. This is an integration profile that we ended up developing as part of the patient summary project because we had to solve for something that hasn't been solved internationally. So looking at this in a slightly different format, this is where we're introducing that concept of reference architecture that you may remember I was alluding to when I was talking about the companion guides to the specification. One was about the reference architecture. So the way we are trying to foundationally support the interoperability objectives, the interoperability products that we're building as part of the roadmap, is that we're trying to take these building blocks and start assembling them into something that we call a reference architecture. So what does this mean? What it means is that if you look at this, and again, you don't need to read it, you can go to the website and you can zoom into it and you'll see it way better. But the idea is that we try to sort of suggest that every problem that has an integration profile usually has, there's different ways of saying this, a client side and a server side. That's one way of saying it, or an actor that does a particular type of transaction and an actor that does a different type of transaction. Then you can look at it also from the perspective that typically some of these server actors or actors that are usually managed by e-health teams or jurisdictional governments, health teams, would reside in publicly funded spaces where data custodians are going to be collecting data and they're going to serve it up, right? Whereas the top layer, where we're saying clinical systems, these are market systems that you would see in a typical EMR office, physician office as an EMR system, or you could even imagine as aftermarket components that customers like patients could purchase in order to process their own data. So approaching the problem with this reference architecture concept allowed us to start identifying what are the ingredients that we would like to see in the ecosystem in order for patient summaries to really take off. And we have listed here the ones that were FHIR-based integration profiles. And we introduced the parlance that integration profiles have actors and actors have transactions. So if you understand this, then it's very easy to understand the rest of the narrative, because these are the core concepts. And why do we do this? We do this because we would like to get to the point where we are able to have a conversation with the market, with vendors, and make it very clear that, let's say, if this rectangle in the middle, which I call clinical systems, is a vendor product, vendor products are free to compete with one another or pretty much everything, except for the three blocks at the bottom. These are those integration profiles that I alluded to previously. So the authorization client, for example, to act as a Canadian Fire Exchange data source or a consumer, because if we start doing this, then we are going to be able to have conversations where we can say that this vendor system is able, as they claim, to operate as a secure node, to authorize their users and submit and receive patient summaries. That's basically how you will translate the technical definition of that integration profile. So you can have a very predictable, objective conversation, and it's no longer waving arms as to what is your product able to do. So employing this methodology then, it starts opening up a completely new opportunity to sort of reach out to the market and start controlling change in the market. And how do you do that? Well, we decided that we're going to employ building block number 4. It is called Gazelle. Gazelle is an open source application developed by IHE International, and it's basically a compendium of a number of international and national profiles and transactions, these integration profiles that I talked about. And IHE International has a library of capabilities that others have developed, and they're all available free of charge at IHE International. Gazelle is a framework application that knows about these integration profiles and allows to create technical interoperability events where vendors can bring their solutions that claim to be able to play those active roles, and then can connect to this system and execute the so-called connectathons or projectathons, which are events where one vendor is going to communicate with another vendor through the platform, and they're able to test whether or not their claim is correct. So in order to better understand how this works, there's a couple of concepts that I would like to put on the table. So think of it as breaking down the complexity of a vendor system and start introducing the concepts of vendors being an organization that have multiple clinical systems, so they can bring one or multiples for testing. And each clinical system has one or multiple integration profiles. Each integration profile has at least one, if not multiple actors, usually at least 2. And then there's transactions between these actors. And I gave you a little bit of a hint as to what this looks like on a previous slide. So then the way Gazelle works, it's got this test management system. The test management system is the front end that exposes all these integration profiles as basically a compendium of capabilities. And then a vendor system that says, I implemented some of those capabilities and I can prove it to you that I can do it, connects their system to Gazelle. And then at that point, that clinical system becomes the system under test. It's operated by one of their technology people or an entire team for that matter. And then they can connect their system through Gazelle to either simulators and emulators and exchange the information that is required by the specification through these channels. We call them the proxies. And the proxy captures those signals, that message transfer, and what it can do with it, it can subject it to a number of validators through the so-called EVS client, which is the verification service client. So doing this, vendors can get ready for the big technical events, and then big technical events are going to be no longer using simulators, emulators, rather they're going to go head-to-head. They're going to test against one another. So the previous one was just a prelude, a preparation. It's in line with the specifications. So once the vendors learn the specification and implement it in their products, now they come to a connectathon event or a projectathon event, and then one system communicates with another system. And there's a team of monitors. It's called test session managers and monitors. And they are going to walk the conference floor and answer questions if vendors have issues. And then after that, basically judge the test results of these transactions. So this is an example of some of the dashboards that they would be seeing while performing the tests. Depending on the type of capability the vendors have signed up for, they'll have more or fewer tests, obviously, to complete. So we found that this is a very, very subjective way of telling where the market is. And we decided to organize this year the second projectathon. Some of you may have heard that in March of 2022, we introduced the first pan-Canadian projectathon, which was a very big novelty for Canada. This was the first time that we tested the methodology in action, but it was mainly focused on trying to make sure that the specification was right. So we invited vendors in indeed, but we wanted to get their opinion as to whether or not the specification satisfies what needs to happen for patient summaries to flow. So as you can see on the left side, it was more of a feedback loop on itself to make sure that the specification is proper. This is how we ended up with a trial implementation version. In other words, the quality was very good, and it ended up progressing to the next level. And then this year, the focus was a little bit more on adoption. We were no longer looking for finding bugs in the specification. Rather, we wanted to see how well vendors are adopting this and how they can reproduce patient summaries. So the focus of the projectathon this year was to basically test for both. Remember, this is a category 2 specification. So we wanted to test for both. We wanted to test for the accuracy with which the patient summary document is created, but also we wanted to test for what type of methods do they support in order to exchange the patient summary, referring back to the reference architecture. So Alberta and Ontario, as I mentioned, were working with us very closely, and they're one of the earlier adopters of patient summary. So Ontario already had an implementation guidance for adopting patient summary in Ontario, and Alberta is very close behind. Unfortunately, Alberta didn't manage to finish the implementation guide by March 20th. Therefore, we could only test for the PSCA and the PSON. But a number of vendors actually signed up to prove that they can create patient summaries for the Canadian scope and Ontario scope. And then we also tested for a number of the integration profiles. When it comes to integration profiles, we wanted to, again, split the tests into two categories. We wanted to give vendors an opportunity to test for their capabilities one by one in isolation. Of course, against simulators and validators, but in isolation so that they can prove that they can, for example, act as a secure node, meaning you can do safe exchanges over the internet, that they can act as an auditing facility, meaning that they keep track of what's going on in the system, who's accessing what and what events are happening, that they can act as a Canadian Fire Exchange client or server, depending on the role they were playing, and that they can also act as an internet user authorization agent. So you can see here the types of integration profiles that we chose for this particular thing, because overall we wanted to be able to say a story something like vendor A managed to create a well-formed patient summary and securely transferred it to vendor B over the internet, and vendor B received it and understands it. So that's a story where you're actually starting to see interoperability in action, and it's predictably proving that the content actually transfers very nicely. So in order for this to work, we ended up building a number of simulators and validators. Some of these simulators are absolutely homegrown, but based on the most modern programming languages and approaches. This is a Swagger interface of the actual implementation of CAFAX and MHD. And we also do a lot of collaboration internationally. And this is the Inferno validator that has been adapted to the Canadian patient summary specification to be able to test against the implementation guides that we have in the country. So these were available to the vendors. So it was a really good event. We had 3 days of testing and 1 day of symposia. During the 3 days of testing, we have a little of statistical information here. 9 vendors showed up this year to test. Previously, we had for the first event, we had 5. The good news is that we had 7 Canadian vendors this time around. Last year, we only had 2 Canadian vendors out of the 5. This time around, we had 7 and 2 international. And pretty much everything was tested in the 3 days, although it was really short. Vendors were under pressure to perform as many tests as possible, and we published a report of the projectathon. I believe I have a link to that, and I will also show you a sample result of the event as to how is it presented back. But before I go there, I wanted to just say a few words about the Symposia Day. So on the 4th day, what we usually do is we try to take advantage of the fact that a number of professionals are together. The focus is there. The talk is all about interoperability. So we want to invite in even more people that are very active in the space, both Canadians and international speakers. So we had the pleasure of having a keynote speaker, our colleagues from eHealth Swiss, so from Switzerland's Ministry of Health. They have also approached their interoperability agenda in Switzerland using a reference architecture approach. And they are a couple of years ahead of us in their journey. They have a significantly more experience, and we would like to learn from other countries that are doing it very well. And they were very kind to come and have a talk, tell us their experience. And all these 4 Symposia Day presentations are also video recorded, and they're available on Info Central. I believe there's a link there at the bottom where the recordings can be accessed from. So before I basically wrap up the projectathon, I just wanted to give you a sense as to why the projectathons are extremely useful. When you look at the table on the right, and you have the legend on how to read it on the left, you will see that this is invaluable information for a jurisdictional health team that is trying to design and architect an interoperability platform that is going to have to do certain things. Why? Because what you have at the top is representing the actors and the integration profiles that we used when we designed the use case that we would like to satisfy. And the left side shows you what is the market readiness and availability and capability out there to support the particular transactions that you're looking for. Now, if somebody doesn't have a green, that doesn't mean that they cannot do stuff. It just means that potentially their product is not appropriate for that particular role. Nevertheless, when you start doing this for a number of integration profiles, suddenly you have almost like a compendium of capabilities in the marketplace, and you can start designing all sorts of interesting deployments of healthcare solutions because you know that the market is ready for it. So we're hoping to then use this particular approach and start scaling up these building blocks here. I'm pretty sure Abby talked about this because it's part of the roadmap, but core capabilities in the ecosystem could be very nicely modeled using integration profiles, could be represented on reference architectures, and they should allow for a variety of deployments across the country without breaking interoperability. In other words, not every jurisdiction has to have the exact same topography in order for them to be able to exchange the exact same information. So that's the hope. That's the hope that our jurisdictional colleagues are going to buy into. What's next for us is to go a little bit beyond the patient summary in Ontario and Alberta and hopefully get BC interested in this and Newfoundland. I know that they were at the table when these were being developed, and now is just starting to grow and focus significantly more on adoption. So that's basically the information, the deck that I had for you today. So I'll stop there and see if you have any questions.